Yeah. Thank you very much for the invitation. It's a great pleasure to be here. Would you like me to start now, or do you want to wait for a few minutes? It's up to. Okay, good. All right. So I'm Alex Miras. I'm an endocrinologist. I work at Imperial College London, and I spend most of my time treating obesity. So I will be talking about medications that can induce obesity and discussing some of the largely unknown mechanisms of action and what can be done from a very practical perspective in order to treat this type of obesity, which actually is not that different from other types. So these are my disclosures. And I'm showing you the brain, the organ that is responsible for obesity in the absence of drugs, and this is the brain. And we've got, in a very kind of simplistic term, we've got two areas that you might be able to see here from these dotted lines that control food intake. We've got the homeostatic control of food intake, i.e. hunger and fullness. And this is controlled in the hypothalamus and the brainstem through the different complex nuclei that I will not be going into. And also, what we also have, apart from this system, which is probably the most important in terms of body weight regulation, we've got this area here of the brain, which responds to other cues independent of hunger and fullness sometimes, and these are the rewarding values of food, for example, stress, which is a very potent promoter of food intake, emotions, mood, and so on. So it comes to you with no surprise that all of the medications that induce weight gain, they do that by changing the brain. And it's a very simple thing. They increase appetite in the sense that they increase hunger and they decrease fullness, which is exactly the same cause, biological cause of obesity in the absence of medications. There is some evidence that some of these medications might potentially affect energy expenditure, but I'm not sure that this has been conclusively been shown. And again, most of the contribution in terms of weight gain comes from eating more. Okay, so what I'll do is I'll go through the different classes of medications that can induce weight gain, and I'll probably keep saying that these are terrible drugs that I will be mentioning, because as an endocrinologist, obviously I see the side effects. They can certainly be effective for the other indications that they are given, but they're terrible drugs, as I say. So one of the drugs that I hate the most is insulin, because certainly, obviously, in type 2 diabetes, type 1, you don't have much options, because it might control glucose control. It might have an effect potentially on micro and microvascular complications. But the weight gain is almost inevitable. This is data from the UK diabetes prevention study, and here we've got the change in weight and the years from randomization. Don't worry about this part of the slide too much. This is insulin. This is chlorpropamide, which is in sulfonylurea, so we'll be talking about both. And you'll see the rapid weight gain after initiation with certainly with the first year, you see this steep increase in weight. Similar increases with sulfonylureas, but a little bit of a less weight gain and a plateau after the first few years compared to conventional treatment. So I remember back in when I started in diabetes in the early 2000s or so, when I had this kind of uncomfortable discussion with my patient, where they would come and I would say, but your HbA1c is better on insulin or sulfonylureas, you're doing very well. And they would say, no, I'm not doing very well because I'm putting on weight, but your HbA1c is better. And we kept going back and forth into this discussion, because obviously weight gain for the patient is very important and leads to poor compliance with their medications. So I cannot blame them. How do insulins and sulfonylureas, most insulin sulfonylureas, work? Well, they make you feel more hungry. They make you feel less full. These are some of the changes that you see here. This is a nice paper from Diabetologia going through just some basic mechanisms. So you're seeing the changes in body weight. Here in terms of dietary intake, you're seeing what happens when you have insulin on its own. Sometimes you might be able to mitigate the effect, of course, of the insulin by giving metformin. So the other mechanism of weight gain is the fact that you're not peeing glucose anymore. You are retaining glucose. Insulin is an anabolic hormone for glucose, protein, and fat. And finally, the final mechanism that insulin causes weight gain is through the avoidance, sometimes overzealous avoidance of hypoglycemia, in which patients tend to overeat to avoid, or when they are having indeed frequent hypoglycemia, and that certainly contributes to the weight gain. There are more and more insulins coming out in the market, very sophisticated compared to the one that we were used to in the 90s and early 2000s. This is an example of Levemir, and there is a little bit of evidence that it might be a little bit better than the other long-acting insulins in terms of weight. Here is a trial where patients were taken NPH insulin versus, so this is NPH in the white bars, and this is insulin detamir, and you're going to see that people on the NPH gained about 2 kilograms or so more than patients on insulin Levemir. We're not entirely sure as to why Levemir might be a little bit better for weight control. Some theories are that it penetrates the brain more and it reduces activation of the homeostatic and reward systems of the brain. Pioglitazone is a medication that is, for some reasons, less and less used. I like pioglitazone not to use in patients, but as a concept, because unlike insulin, and unlike other medications, what it does is that it increases your body weight, but it improves so many other cardiometabolic factors. Which shows that weight gain on its own doesn't mean that you will necessarily become unhealthy, because what pioglitazone does is that it shifts the fat from the visceral areas to the subcutaneous areas. And when you have fat around your bum or your thigh, that's a lot better than having it around your liver, for example. Obviously, the patients are not happy with that either, but from a cardiometabolic perspective, it is a lot better. And these are some of the areas where pioglitazone has got an effect. The second cause of weight gain is through fluid. So we've got water retention, and that is obviously another problem with pioglitazone that can potentially worsen heart failure. So these are the two mechanisms there. But in these very nice studies using clamps and other measurements, when it was used for fatty liver disease, non-alcoholic steatohepatitis, amongst other things that it improves, you're going to see the nice improvements with pioglitazone in terms of liver fat, hepatic insulin sensitivity, muscle insulin sensitivity, and adipose tissue insulin sensitivity. So weight gain associated with improvements in insulin sensitivity, which is always a very interesting concept. Okay, so that's a brief summary of the bad diabetes drugs. And we will be talking, of course, about the newer ones soon. Steroids are, again, another terrible class of medications that sometimes cannot, of course, be avoided given in rheumatological conditions, autoimmune conditions, kidney transplantation. We see a lot of weight gain, not only from this type of immunosuppressant, but from the other ones as well, even the more modern ones in patients who have had kidney transplantation. They come to us and they balloon up after their operations. The weight gain is variable, obviously, depends on the dose of prednisolone or whatever steroid you use. 10 kilograms have been reported. And the mechanism of action, again, taking it simply macroscopically, we're talking about, again, increases in appetite, but also changes in food preferences. So there is a predisposition for these patients to start eating more fat and high glycemic index food. What are the mechanisms in the brain? There are some suggestions from animal models that AMP, protein kinase, and endocannabinoid system activation can contribute to these changes in appetite and eating behavior. The glucose intolerance appears to be dose dependent, and we know obviously about the risk of developing type 2 diabetes in those patients. Just a tip there before I forget. This is what we're currently doing at Imperial in patients who have got pituitary-induced hypocortisolemia. We used to give hydrocortisone, and for some clever company managed to make a lot of money from developing a license on hydrocortisone, which is now incredibly expensive in the UK. The price has gone up more than tenfold. So we're now switching all of our patients to prednisolone. And we've done some pharmacokinetic, pharmacodynamic studies, and obviously clinical outcomes. And we're seeing that with very small doses of prednisolones, these patients are doing really well, and prednisolone is very cheap. So most of our pituitary patients are kept at about 3 milligrams of prednisolone. We're doing a randomized trial to see what their quality of life is and how different it is from hydrocortisone. I don't know what the cost of hydrocortisone is in Greece. Right, so this is what happens when you give prednisolone. You pay not for replacement, but for treatment, and this is only a very small dose. It is 6 milligrams for 7 to 10 days, a short acute course of steroids. You can imagine what will happen if you give higher doses for longer. And this is a clamp study. So EGP here stands for endogenous glucose production. So the higher the glucose production from the liver, obviously, the worse your insulin sensitivity. And here you're going to see that non-glucocorticoid users, post-prednisolone, you see the increase in the amount of glucose that the liver is pumping out into the circulation. The same happens if someone is on chronic use, so the effect is dose dependent. All right, so that's steroids. I'm now moving to an area of increasing interest of me from the clinical perspective mostly, and that is that of mental health disease, which has over the decades been hidden just because it has been stigmatized and has a stigma against mental health disease everywhere around the world. So you can imagine that if you've got mental health disease, certainly psychosis and severe mental health disease, no one really cares about you. If you have got that and obesity, which is also stigmatized, you can imagine that the combination doesn't attract much attention. But now it is, because people have realized that patients with psychosis and severe mental health disease live 20 years less than the rest of us. That's a lot of years less than the normal life expectancy, 20 years. The factors are numerous. We all know that these patients are predisposed, probably even before medications are started for their mental health illness, to developing obesity, interestingly enough, to developing type 2 diabetes. So by giving them their antipsychotics would just make an already a bad situation, a predisposition, would just make it worse. We unmask it. We know that these patients smoke a lot, even before they are given antipsychotics, and their energy expenditure, their physical activity is pretty low. What other factors contribute to the obesity, but mostly the metabolic disturbances in these patients? We've got a lot of inflammation, and the inflammation takes place both in the periphery, in adipose tissue, in the liver, but also in the brain. And there is this bidirectional relationship between obesity and mental health disease. Mental health disease patients are obese, and obese patients have got mental health disease. The other system that's affected by this is the HPA axis. the hypothalamic pituitary adrenal axis. So we have got a exaggerated response and a continuous overstimulation of the adrenal glands to produce endogenous steroids. And that is in the context of stress. And we know that even if you're not stressed because of your psychiatric illness, but if you're stressed because of life, we all know how many of us respond in terms of emotional eating in order to deal with stress. So stress is a very potent stimulator of appetite, mostly chronic stress. So here you're going to see what antidepressants do. I mean, I cannot say antidepressants are terrible drugs. They're not too bad. And this is a nice meta-analysis where you're going to see that the worst antidepressants are these ones. In terms of weight gain here, you're going to see in the mostly early phases after treatment. Amitriptyline, mirtazapine is a very commonly prescribed one in the UK because the GPs love it because it makes people go to sleep. The problem is that it causes weight gain as well. So if you move now to the more SSRI type of antidepressants, you're going to see that fluoxetine and sertraline and citalopram tend to be the better ones. So in my clinic, in our unit, we tend to use fluoxetine. The venlafaxines, paroxetines are not that great. Here you're going to see bupropion. I'm not sure whether it is being used in Greece. It's not used in the UK much, which is a shame because it is associated with weight loss, and you're going to see a little bit of the data about that later on. Antipsychotics are terrible drugs. They might work for mental health disease, but their cardiometabolic side effects are horrific. Certainly the older generation, the clozapines and the olanzapines, you were seeing immense changes in weight. And they tend to be dose dependent. They tend to be, obviously, the more compliant the patient is, the more the weight they put. But you see here, when we're going to the newer ones, you're going to see that we can reduce some of this weight gain. These are the newer antipsychotics. Aripiprazole is meant to be the best in terms of weight and metabolic side effects. So, if you have to choose something, try and choose this one if you can. Psychiatrists tell me that this works beautifully for mental health disease, but it's bad for diabetes, of course. This doesn't work beautifully for mental health disease, so that's why they're forced sometimes to use the older ones. But this is just a map to show you where the receptors that some of these medications work. You're going to see here a lot of dopamine stimulation, which means that not only are patients going to be feeling more hungry and less full, but again, their food preferences change and they go for the junk food. They go for the high-fat, high-glycemic index food. And this is, again, just a map of and kind of a slide with nice colors that show you some of the mechanisms through which these medications work, not only to change appetite, but here in the periphery, we've got a decrease in insulin sensitivity in muscles, so peripheral insulin sensitivity. There are some reports of decreases in actual insulin secretion, more insulin resistance in muscle and the liver, contributing here to fatty liver disease and steatohepatitis. And obviously, we had to involve gut bacteria somewhere because everyone likes to involve bacteria in everything in science these days. And yes, there are reports that antipsychotics may also change your gut bacteria, but obviously, who knows whether this is cause and effect. It might be because they changed the diet and the microbiota changed as a result. Epilepsy medications. I do see some, epilepsy weight gain in clinic, not as much as with the other medications that I have described, probably because neurologists are moving away from these older classes of epilepsy drugs. So Keppra and so on are being used more frequently, and that's probably why I'm not seeing much of that. But if you use, this is a typical example of weight gain when you're using sodium valproate in this graph, but similar results can be obtained for carbamazepine, phenytoin, And unfortunately, pregabalin and gabapentin as well. The implication and the problem here is that pregabalin and gabapentin are used for peripheral neuropathies in patients with diabetes, and certainly they contribute to weight gain when we use them. They're pretty good, though, for sensory neuropathy, so they were a difficult balance. This is the sodium valproate specifically appears to have weight loss independent deleterious effects on metabolism, and here we've got its effects on adipose tissue in terms of insulin sensitivity decreases, and possibly toxicity to the pancreas itself. All right. I think I've talked quite a lot about the problem. We now need to move pretty swiftly, I think, to the treatment. And it doesn't matter what the cause of the weight gain is, molecularly or metabolically, with these medications, because our treatments for obesity are so crude that we just have to use whatever is available. A very important, simple concept, possibly, but one that I will ask you to remember is that not only in this context, but also in the context of obesity without the use of medications, is that I've shown you previously that the hypothalamus and the brainstem here are involved in body weight regulation. And what you're going to see is that they are located in the part of the brain that it is white, in simple neurological terms, whereas the outer parts of the brain, the ones that make us think and do mathematics and philosophy, are the gray matter of the brain. Now, there's no point in the same way that if someone we tell someone to stop breathing, and we know that the breathing centers of our brain are located here in the white matter. And we tell them, if you stop breathing, we're going to give you 2,000 euros. So the person says with their cortex, that sounds like a very good idea, right? So I'm going to stop breathing. The cortex tries to suppress the medulla oblongata that controls breathing, but eventually you're going to start breathing again because your body said this is not a great idea. So you're not going to get your 2,000 pounds. So there's no point telling patients to eat less and exercise more. There's certainly no point in telling them to reduce their calories and feel hungry. Initially, that might sound like a good idea to the cortex, the gray matter of the brain, and it will try to suppress the hypothalamic and brainstem signals, but eventually you will lose. You cannot fight your physiology. What instead you could potentially tell your patients is to change their habits, change the macronutrient composition of food, change their food preferences, not reduce the calories by a huge amount, because that will make them feel hungry. And in general, anything that causes hunger in obesity treatment is doomed to fail. So some basic principles, and because I don't want to overrun too much, weight gain with these medications is observed very early. So if you see weight gain within the first few weeks, it means that they will continue to put on weight later on. If they don't put on weight, that's very good news. It might mean that the drug is not working, but at least you're not getting the weight gain. And obviously, stop the drug if you can. This is particularly, we should be trying to stop the drug if we can more in diabetes. It can be more problematic in other areas. Okay, I won't go too much into the lifestyle changes, but we can discuss them later if you want. What do we have in Europe? In the UK, I don't know if you consider it Europe or not. We've got naltrexone and bupropion, which is a combination that works on the hypothalamus. Bupropion is an antidepressant. Therefore, you might want to consider it even in patients who have got mental health disease for weight loss. The side effects are irritability, insomnia, so you might just want to watch for those. It doesn't mean, though, that you should not start the drug. Start the drug and watch for side effects. If there are side effects, you stop it. Phentermine and topiramate is a beautiful combination for weight loss, but it's not available in the UK. It's very potent. Topiramate is an anti-epileptic medications that you actually might want to use in the first place in the context of epilepsy. But here we might have more neuropsychiatric side effects. So I would be more cautious, specifically in the mental health disease population. Lorcaserin recently been shown to be cardiovascularly safe, small weight loss, and not available in Europe, so unlikely that you will have too much access to that. Liraglutide is a medication that we like, and because it's clean in terms of side effects. If anything, it has been used and being rather trialed to treat brain conditions like Alzheimer's and Parkinson's, and generally patients feel better. This is a slide to show you that liraglutide has been used in a mental health disease population with decent effects in terms of weight loss and glycemic improvements in patients with psychosis taking olanzapine. This is the Godzilla, as I call it, of GLP-1s. It is called semaglutide. It's coming out soon, hopefully, here as well, for diabetes, and the 2.4 milligrams for obesity will probably come out in late 2019. This is a very potent it's not just another GLP-1 receptor agonist. This is a game changer. We're talking about mean weight loss of 14%, with 25% of patients on semaglutide losing more than 20% of their body weight. So very impressive effects, very clean profile in general. So we're really looking forward to having that. SGLT2s, please try and use as much as possible because some weight loss, not much, but more importantly, they reduce cardiovascular events. And this is really important in patients, for example, that have got psychiatric disease that do die early, but obviously in patients with diabetes as well. And this is, even though I'm an endocrinologist, this is my favorite treatment, which is obesity, bariatric surgery. By far the most effective treatment for weight loss and diabetes, as has been shown by large trials like the SOS, and here this is the STAMPEDE randomized controlled clinical trial, much more effective than what I can achieve as an endocrinologist, very safe, and in good hands, very safe in the long term. These are the three most commonly performed procedures: the gastric bypass, weight loss of approximately 25%. Gastric bands are going down around the world because of problems, so I wouldn't recommend that too much. Sleeve gastrectomies are increasing in popularity around the world and cause very similar weight loss and glycemic and metabolic improvements to the gastric bypass. And in summary, I want to say that if you are going to take those patients and change their medications, or if you're going to take them and treat them with new medications, what you should do is you should see what happens within the first 4 months of treatment. Because within the first 4 months, you're going to know whether your patient is a responder. There's no point keep telling the patient, try more and try this and try more, try a different diet if it's not working. And you know that within 4 months. If your treatment is not working within 4 months, it will never work. So you might as well stop it and use something else. Thank you. These are my collaborators that I would like to thank, and I would like to thank you for listening, and sorry I've taken a little bit longer.